بسم الله الرحمن الرحيم.
Discussion on the speaker is Sergio Vanessini. Please, Sergio, your presentation.
Thank you so much, Luigi, for the introduction, and thank you to all the families and friends from Egypt and all around. I've been asked to talk about suffering-sparing surgery, but considering the friendship, I will allow myself to change the title a bit in laws of physics in the operating room. When we are talking about suffering-sparing, indeed, we are applying the laws of physics. I have no conflicts of interest related to this topic to declare. Well, I declare that it will be quite challenging in 10 minutes to cover such a broad topic, so I will try to give you 10 reasons why we want to think hemodynamically whenever we are approaching the disease. As I was saying, I have no conflicts of interest, particularly because this is all about the physics. It's about those laws that are ruling the venous drainage back to our heart. And indeed, if we go back to the physics, we remember the Poiseuille law that is stating that in order to create a flow in between 2 points or a reflux in the opposite direction, we need a pressure gradient. And indeed, if we look at the golden rule in the detection of refluxes, it is not the fact of just detecting the reflux, but really understanding where it starts and where it ends. A typical example can be an incompetent saphenofemoral junction that is indeed the starting point of a reflux that is ending at the re-entry perforating vein. So our golden rule when we are applying suffering-sparing is, of course, whenever we detect a reflux, to identify the leaking point and the re-entry point. And this re-entry point can be focused, for example, along the saphenous trunk and or along the incompetent tributary. In order to understand where this re-entry perforating vein is, we just need a digit compression of the incompetent tributary. If we see that the reflux is disappearing, it means that we are stopping the pressure gradient in between the leaking point, that is at the saphenofemoral junction, and the re-entry point, that is along the tributary. If by compressing the tributary we see that there is still a reflux, it means that we have another re-entry point that is focused along the GS. Again, it's important, I think, just to have the take-home message here that with one finger we can change the pressure gradient and assess what is going to happen if we fix the leaking point. But there is nothing new in this, and I really like the quote of a huge master from the past, from the Strict, who was saying that we should know the history so to avoid wasting our time trying to open doors that were already opened by others. If we go back to the Figan group, they were already talking about the reversibility of the saphenofemoral refluxes back in 1971, indeed. And if we go back to 1981, we see that they were already talking about the multiple origins of refluxes, so not just the saphenous trunk, of course. So if I had to cover the 10 topics in 10 minutes, I would say, why should we ablate all the saphenous vein when it is physically demonstrated that by finger compression we can already suppress the reflux. And indeed we have everyday situations like this one, operating room, where we see a nice saphenous trunk that has really done nothing bad as anyone, and we have a very tortuous and incompetent tributary vein that is the source of our reflux. So we should really ask ourselves, we culprit in a situation like this. Of course, we must know our leg anatomy very well, and we should know very well the network we have in it. And indeed, we published a paper looking at the different velocities we have in the different compartments. Now, if we look at the anatomical structure, we see that the tip system is inside the muscle mass. This means that whenever I'm contracting the muscle, I have the highest pressure values that are giving the highest velocity. Then we have the saphenous compartment that is like a natural stocking. And we have my hero, Professor Caprini, who is always talking about the giraffes. And indeed, it's like the skin of the giraffes in sort of way, this fascia that is protecting the dilation of the vessel. And then we have the incompetent or competent tributaries that are navigating and floating in between the adipose cells, which means that they are not as protected as the other compartments, and indeed the pressure levels are going a little bit lower, and then we have indeed lower values of velocity.
What we demonstrated is that you have a pressure gradient that is leading to a velocity gradient that is increasing in physiology from the surface toward the deepest compartment, which means that we apply also the Venturi's effect, an aspiration that is going from the surface toward the deepest compartment. In another publication, we demonstrated that whenever there is a reflex, we have a subversion of this velocity gradient, which means that we have an aspiration toward the surface. So we just need again to change this pressure gradient to restore also the velocity gradient. So why should we avoid the highway that is the saphenous trunk in this drainage, just removing that rather than fixing the leaking ponds? There are objective data also supporting this. These are studies done by air plethysmography showing how restoring the pressure and the velocity gradients, we have an improvement in the plethysmographic parameters with the exception of the ejection fraction. We have also publications that are showing how in advanced cases of disease like in C6 patients, we can find an improvement with this approach. So it's not just for the mild cases. And this is very interesting to me, this publication from the Carandina group, because it is showing that at 3 years, there is no significant difference between a saphenous sparing versus an ablative approach. So if we just look at 3 years, the survival curve is basically overlapping. But then if we go at 10 years, we have a significant difference in terms of recurrency. So the importance also of the follow-up we want to give for our patients. So again, the question is, should we ablate when we can restore this drainage? And should we use these new devices? Because we should, first of all, be honest with ourselves and the patients in pain. We have multiple new techniques that are constantly coming into the market. But this does not mean that we have new strategies. So we have new toys, but either we strip it surgically or burn it by thermal ablation or do it by chemical ablation. We always have the same ablative strategy in the end. And in the end, indeed, we see that in the last decades, we haven't changed that much the recurrence rate. And indeed, the strategy is the same one that was first described by the Abucacis of Cordoba in the first textbook dealing with the stripping procedure. So in my vision, it's like giving birth to a new web mainstream the army to move always in the they directly use a king minds to follow the guidelines, but also understand where we stay in terms of improvement of, for example, recurrence rate and the different outcome measures we want to look at. Because indeed the same guidelines are pointing out that thermotumescence is the way to go in this moment in terms of benefits, but not because of a better recurrence rate, rather because of the mean invasiveness. Cochrane reported the data showing the potential reduction in the recurrence rate. And just now, Sergei Montoya published another Cochrane questioning this data. So there is no final conclusion on this, apart the one that we should really think hemodynamically to improve the outcomes for our patients. We have data coming from this meta-analysis suggesting once again that hemodynamic approach can have significant benefits. It has been demonstrated clearly in this. So, also in terms of anatomic currents, also in terms of quality of life and clinical outcomes in general. This is what I consider one of the most important papers of our research group because it focused on the cytokine variations following a saphenous sparing procedure. So once I restore the hemodynamics, how is this translated in terms of inflammation? And we demonstrated that IP10, MANDES, and PDGF, so the platelet-derived growth factor, is normalized after saphenous sparing procedure. And it's lovely to have once again here Professor Caprini because this could be related also to the thrombotic risk associated with varicose veins, and we really look forward for engaging all of you in registry activity related on your activities in terms of thromboprophylaxis in venous procedures. So why not restoring inflammatory biomarkers as we demonstrated by these procedures rather than just ablating on the saphenous trunk? Also because we have papers like this one showing that the escape points are usually located not just as a phenomenon junction, but mainly actually along the saphenous trunk. And if I just treat the saphenous trunk without taking care of the leaking point of the tributaries, I actually get the risk of increasing recurrence rates because I lose drainage road. So why not targeting the escape points rather than just that trunk? And of course, we also want to look at the cost effectiveness of thing, and we understand that by mini-invasive surgery we can approach these patients and have a satisfactory result. But of course, when we are talking about cost effectiveness, we also want to look at the new devices. And this is a publication of our group that compared laser and radiofrequency in a saphenous sparing approach, which means that we use the laser and radiofrequency to have a segmental shrinkage, so not ablating all the trunk, but just 6 centimeters at the saphenofemoral junction, applying hemodynamic selection of patients and then treating the tributaries, showing an improvement in the quality of life. But of course, we are just at the beginning because the follow-up is very short with 12 months. You can find this in Phlebology Journal. So cost effectiveness and time effectiveness is surely something we want to look at in the discussion. I kindly disagree with the Shiva colleagues who are pointing out that we want to spare the saphenous vein because it can be used for a bypass. Of course, this is useful, but luckily enough, after years of practice, I've never had a patient really requiring that in a procedure, so luckily enough it's rare, and we know also from the literature we have other potential bypass conduits. I think that of course that is an option to be taken into consideration, but the real reason is the application of hemodynamics and the improvement of outcomes. So in conclusion, always quoting as we do, something we really believe in, that is that in life it's not just where you go, but also who you're traveling with. Another option is to be taken into consideration in the fact that if you have, for example, a DVT, having a potential bypass road is something useful, and if you spare the saphenous trunk, that's another benefit you might have. In conclusion, quoting a huge master from the past, the founder of the UAP, Glauco Bassi, at that time, he was used to say that a modern phlebologist should have known 3 things: surgery, sclerotherapy, and compression. Now, of course, we have to add also the new mini-invasive techniques. But at the same time, I would say that there is still a role for mini-invasive surgery, and if you want, during the discussion, we can discuss about that. We publish a paper on when we stick to high tie without removing the saphenous vein. But whatever we want to do in terms of techniques, if we don't put the strategy in the middle of that, surely we are not to the results according to the decades. The strategy is superior to the technique, and we all studied a lot of pathophysiology and physics, so that might be helpful in our everyday practice. As I think it is very important in our everyday practice to fight fake news. This is a website reporting how 40% of medical websites are actually including fake news shared 450,000 times. And another aspect we don't consider that much in the protection of our patients is also the post-market analysis. So basically there is data showing how easily, in a sort of way, these devices are coming out without proper control in the following years. And this is a hot topic in particular in the new regulation on the medical devices in Europe. This is an interesting study I wanted to bring to your attention. 2,124 filed safety notices over a 5-year period. This is why we are running with the True Care project that is looking at the real aspects of certification of the devices, because it's our responsibility as a scientific society, I think, to protect patients from a situation like this. 44% probability of serious adverse health consequences with devices that have been put in the market and then not really followed by proper data collection. And in reality, 50% of them are coming from the cardiovascular sector, that is our sector indeed. Having said that, of course, I welcome all the new devices. They are fundamental, and it's fundamental at the same time to have them certified in the proper way and analyzed in the proper way in the post-market analysis. Having us fighting fake news, and we want to deeply thank all the societies involved in the group effort that indeed is working on the creation of the consensus. Works to Dubai, and I just remind you that there are 3 weeks to go for the abstract submission deadline. Looking forward for seeing you there in February. I deeply thank all of you.
Thank you, Sergio, for your presentation. Now there is a comment from Professor Medina. This is here.
Bismillahirrahmanirrahim. And first, I would like to thank Professor Ayman Fahri for arranging this big conference. Second, I would like to thank again. First, I would like to thank Professor Ayman Fakhri for arranging this Congress, valuable Congress. Second, I would like to thank Professor Sanjini for his valuable lecture. Actually, the problem of stripping the long saphenous vein dates since long time. Today, I just heard that the first one who did stripping is Abu al-Qasim al-Zahrawi. That's an Arabian that was living in Spain 100 of years ago. That is a new information to me. Second, the problem of stripping is between surgeons, vascular surgeons, and the long saphenous vein. For years and years, when a surgeon sees the Doppler paper saying that there is incompetence in the saphenofemoral junction and the long saphenous vein is okay, you just go forward to strip the long saphenous vein. I have seen this many, many times. Some others, when they see saphenofemoral junction is incompetent and there is some valves in the saphenous vein are incompetent too, he goes forward for stripping the long saphenous vein. Shiva was seen and practiced since 1988 that conserving the long saphenous vein. However, there is no much papers on Shiva up till now. Most of surgeons strip the long saphenous vein. This aggressive attitude against the long saphenous vein should change. I think it is time to change our attitude of removing the long saphenous vein after hearing this wonderful lecture. The long saphenous vein is important for the patient himself. He may need it in some critical situations. And removing it, as we have heard now from this lecture, is not beneficial for the patient. Beneficial is only removing or ligating the incompetent perforators only. The blood which is going out from the long saphenous at a high pressure, making this varicosity, not the long saphenous vein itself. So, I'm asking myself, and am I asking you, is it time to change our attitude towards the long saphenous vein? I think it is time to change. Thank you very much.
I think we may have some questions for Dr. Janizi. Okay, I have a question myself. Thanks, Sergio. I enjoyed your lecture as usual. May I ask you, do you think we are expanding time and money for developing new methods and techniques for ablating great saphenous and still have recurrence? Do you think it's time to spare our time and money to look for sparing the saphenous and not ablating the saphenous? What do you think?
Thank you so much, Ayman, for the very interesting question that is offering us the chance to brainstorm, because one thing is the technique, as I was saying. Another is the strategy. Now, great, it's all the wonderful technological innovations we are enjoying with modern times, but I try to apply them in a hemodynamic approach, in a hemodynamic strategy. So I think it's time to stop saying, I cook this saphenous vein, to focus on, I approach by ultrasound these patients in a very careful way. I collected data in a very careful way. We published a paper in which we were showing how if you don't report the incompetence or not of the iliofemoral tract in a comparison of two techniques, you can have one group having up to 5 times more occurrences, not because the techniques was not as performing as the other one, but because there was a higher pressure value at that than both. So it's very important, I think, we focus on proper strategy in therapy. First of all, proper strategy in diagnostics. So we agree on what every single paper should report in terms of hemodynamics for being accepted in a comparison of 2 different techniques, because if not, we get the risk of comparing apples and oranges. And of course, we welcome the new devices to be as mini-invasive as possible, but not just in terms of ablation of all the segment, but just in terms of suppression of the leaking points and use of the re-entry points to prepare the drainage.
Okay, thank you. We can go ahead. Well, there is a big Canada.
Excuse me,
Very service
still,
for varicose vein.
excuse me, Pierre. You have a still question here in Alexandria?
Okay.
Thank you very much for your lecture, Professor Sergio. Concerning Chiba method, there is a problem that we have to maintain the physiological pathway of the saphenous vein. Sometimes we keep a segment of refluxing saphenous vein so long it's going to the deep system. At the same time, we have to, everyone should do his duplex by himself so that not to skip or...
Seeing the audio. Can you see that again, please? Or maybe you chat, I don't know. Cannot hear that. If not, Ayman, I see Professor Caprini made a question that is actually excellent on the anterior perforated vein, if I can get it.
I'd like to thank Professor Gianzini for his good lecture. My concern about the Chiba method for treating the saphenous, in the state of ablation of the saphenous vein, that sometimes to maintain the presence of the saphenous vein, we maintain a short segment of the, or a segment of the saphenous vein, so long, it may be refluxing, but so long that it's going to the deep system, we keep it. So this is maybe a problem, that there is still a refluxing part of the saphenous, but so long it's going to the deep system, maintaining physiological pathway, so we keep this part of this segment of the saphenous vein. The other point that the one who is doing this Chiba method, he should do his duplex by himself, so that not to skip any point or any perforator that may be against his method. So long that when he depends on another one doing the duplex, he may escape many points, and the results may be not that good. Thank you.
I lost some of the question, but I think I can catch up saying that in a properly done saphenous sparing procedure, because I don't like to focus just on Shiva. You have a different strategic approach that we also as well. So the important thing is to think hemodynamically. We don't need just to focus on Shiva. I think the point is that even if you leave the saphenous vein over there is no increased risk of being thrombosis and going into the deep system compared to the other ablative approaches. So paradoxically, you could that you have higher risk because you have the saphenous vein over there. But if you really dive into the literature, the risk of a thromboembolic event after a saphenous procedure of whatever kind is scaled up to 15%. From wonderful job Professor Caprini is still doing with the EVF doing various ways. Not just because you have the saphenous vein over there, that this means that you are going to have a higher risk of thromboembolic events. Might be the opposite actually, because you are training less. Who knows? We should study for that. That whoever is doing saphenous sparing should be extremely trained in hemodynamics.
This meeting is being recorded.
To do that. I hope you got my answers with the next pages.
Sorry for this technical errors.
No problem. I just wanted to mention that Professor Caprini made an excellent point on the anterior and perforated veins. I don't know if there is time to mention this, but quickly, anterior perforating veins, I think, of Caprini are the answer to the fact that we are failing with the hemodynamic approach. This is the nature that is telling us that the pressure gradient needs to come out somewhere, and indeed, when we look at the ablation of the saphenous vein by endovenous techniques, one of the most frequent causes of recurrences can be indeed an anterior perforating vein restoring reflex in the saphenous vein. In my head, it's like trying to get back into the highway when we got out from the wrong turn.
Professor Caprini.
Okay.
Yes.
Professor Fakri, we go ahead or not?
Yes. Yes, please go on, sir.
Okay. I call Professor Kanata and his presentation about surgery for varicose vein. Please, Victor.
Okay, thank you very much for that invitation. I would like to share my screen, give me a minute and see if I can do it. Are you seeing my presentation now?
Yes, we see it.
Okay, my first question is just for everybody else. We will rely on the people who collect data and check the data, or we will rely on the people who are taking care of the patient and following the patient and taking care of them. I've been doing that for more than 30 years here in Paraguay, and I don't see too much recurrence. I don't see too much stuff that you are seeing it, and I'm being in trouble in the way that you are being in trouble. I think we have to just make very sure regarding about who will be the people in charge of giving the final conclusions for the people who are taking care of the patient. And this is a big difference. There are people who collect paper, people who just give some rules regarding about what's going on already. And this is, I don't think that is 100% true. We are the ones who are taking care of the patient. We are the ones who are seeing the patient before and after. And we are the ones who are following the patient for years and years. And when we see them outside of the office, it's totally different than the conclusion that sometimes they are getting out over there. Besides that, there are a lot of words regarding about this, but I think we have to just follow through the people who are really taking care of the patient. Thanks, Dr. Ayman, for this invitation. I just want to show you something that I got from you from so many years ago. the last meeting that was potential, and I was so happy to get that present from the Egyptian Venus Forum. Thank you very much for that. I have to hear this in my own part. The question is, can we keep digging regarding about cryosurgery? And what is that kind of method that we will just start working? As you are aware, I'm teaching professor of the University of Paraguay and part of the University as well as the Central Paraguay Universities. I'm working very close with my friend here, Pierluigi Antignani in the UIA, and we're trying to develop programs teaching people about saphenous vein, vascular problems around the world, and giving some better results just for the patient. If we improve the quality of the people who are taking care of the patient will get best results. What is cryosurgery? And what is the kind of stuff that is coming out right now? Cryosurgery is some kind of new kind of treatment for the vein that was introduced in 1978 and then was applied for the first time in 1982. And you might see here this a large machine for CO2 will frozen everything else in the patient since you are using it. There is work using a cryo machine, passing a cryo probe, lower the temperature to minus 85 degrees Celsius. You can see a picture over there of the cryo machine and the cryo probe inside of the saphenous vein. Is going inside of the vein, and then you start frozen the tip of the probe. It will go to minus 85, and then you will be able just to do the stripping with less problems that you have usually with that kind of stuff. What are the steps? The steps for this treatment is, the first one is the high ligation of the saphenous femoral junction. Then you inject or you put inside the cryo probe, then you use a little bit of stumescent injection, not too much, between 10 to 20 C, freezing it through the foot switch after 10 to 15 seconds of applying the CO2. You will see that the temperature goes down and you will be able to do the final invagination of the saphenous vein or the side segment like a epiphyseal vein, as well as other segments that you will be able to just put the probe inside, just attaching that probe inside of the vein. The machine is a large machine. It has to be seated at the side of the surgery in the OR. And it's used for people in Poland, as well as Brazil, as well as Korea, where are the people that really start working that kind of surgery. The surgical technique, as I told you before, is going step by step. You go with the high ligation, you find out the saphenous vein, you dissect the saphenous vein, you do the final resection of them, you cut the 2 or 3 collaterals, and then you use the final cryo probe inside of the vein. When you put the cryo probe inside the vein, you try to use the trans illumination, trying to make sure that the probe is going in the appropriate place. Then after this, you have to have 10 to 20 of saline. You add the saline to the vein, then you press the switch of the foot switch, and it will start frozen the tip of the cryo probe to minus 85 degrees. Then, when you do that, you will be able to release after like 2 or 3 minutes of frozen. You will be able just to do the stripping, do the wound closure, apply compression. The patient can go for elevation of the limb and go home without big trouble. What are the pros and the cons of this kind of new treatment? It's a surgery. We're supposed to have this hematome, less ecchymosis, and less complications. And this is the way that we are looking for new kind of treatment. And the other one is already a surgery. You want to be in the OR, you need compression. You can power the complication if you are trained. And there is a new machine that you have to add in your surgical room just to do the treatment. Sometimes it's a little bit tricky, but the surgeons are very well trained. They are able to do it without big trouble. Between the surgery therapy, there is a big difference between pain, between the paper, the people are going back.
There's a problem in the voice, Professor Medina.
There are between regular surgery, patient dripping, and cryosurgery, they are not too much different, but the people who went for the cryosurgery, they developed less complications and more faster than the surgery. Physical exercise, prevention of being affected, don't counter injury. The final thing they do is to for the
I think
false, and
I think
there is another connection.
Yeah, connection in Paraguay is a little bit interrupted.
Yes, there is no good connection with Victor. I wait if Victor can reconnect or not. So, in the meantime, there is some panelists, some
Yes.
comment from panelists.
Yes.
I came back already.
Oh, okay.
I think Dr. Wasila Taha, our big star in
interventional radiology and with the special interest in venous duplex, I think wants to make a comment on this technique of cryosurgery and the talk of Professor Kanata. Please, Wasila.
Yes, Doctor. I had first of all, could you hear me? Confirm if you can hear me.
Yes, it's perfect.
Thank you so much. First of all, I would like to thank the Professor for such kind invitation and congratulations for collaborating with you. It's a great honor and great pleasure for me. Professor Victor Kanata, it's very insightful. For the first part of your lecture, I did listen well, but unfortunately for the rest of the lecture, I didn't hear enough. But I have just one slide, if you can allow me to share it. Please confirm that you see my screen. Here,
it's okay.
here in the
Yes.
GDS 2009, there was a randomized trial, an RCT, which is the highest level of evidence, cryosurgery versus conventional stripping. And as demonstrated very well in the first part of the Professor Kanata lecture, the ligation, the perfectly ligation of the saphenofemoral junction, and then the stripping by the cryo method with the temperature minus 85 and every step as Professor Kanata meant. And the conclusion of this RCT was the cryo stripping accounts for numerous procedure failures, hence there is a residual GSB in patient. And I have a short question here for this point. And another important conclusion that the cryo stripping has no benefits over the conventional stripping. My question for you, Professor Kanata, if you can hear me still, for the remaining GSB, does guidance by the ultrasound, by the duplex during the procedure of the cryosurgery, could be additive advantage for this procedure, could be really ameliorate and improve the results? This is my first question. And my second question, why it's not so much spread? Does it need a learning curve, or what do you think? We are not really very, it's not a widespread modality like the RF or the thermal modalities. And thank you for the opportunity. Thank you so much for the opportunity.
Please, Victor.
Are you still with us, Dr. Kanata? I think we lost connection.
This is not with connection.
Yeah. Okay, Professor Antoniani, you can go for the next speaker, please.
The speaker is Professor Solgan, nephrectomies in treating varicose vein. Okay.
Yes.
No. Okay.
Found that census has advocated the process of lipectomy, and reps already introduced the first box, but Muller redistributed and rediscovered the technique in 1956. One of his students, Ramley, has introduced a new box for smaller reticular veins and refined the original process of his box. Looking at the process, the ideal of to start with should have a sharp harpoon to engage the adventure and to allow proper extraction through minimal incisions and having a comfortable grip at the same time, but not using the blunt hooks because they require a larger incision and they need an aggressive kind of dissection that may cause nerve injury. Larger hooks or smaller hooks is an optional according to the size of the vein. And starting with Ramley hook, this allows catching and engaging the venture from above, while the Irish hook can catch the adventure from the side, and the traditional model can get it from below. What Farad is the extractor which combines two devices on one stem. This means a spatula at one end and a hook at the other, and the operator can use the spatula for dissection and for grasping of the veins and reversing the device in his hand every time. The trans-eliminated power cystectomy or the EICV is a kind of cystectomy, but it is done in a more aggressive way, and it needs an eliminated humectant introducer, and two incisions are made close to the approach vein. One is for the trans-elimination that allows a better visualization of the target vein, and the other one is the device used for section of the vein and fragmenting it into small pieces, and we can have this kind of result, whatever the distribution, whatever the location, and get almost a nice appearance. As an indication for the cystectomy, we can figure that it is around targeting all kinds of reticular and truncal veins below the junctional reflux, which has to be corrected first, otherwise we will get a short-term improvement by the phlebotomy, and occasionally we may need this process in a deliberate way, like in a young lady in the postpartum period with a single painful varicosis, and she doesn't need to go for an extensive surgery. Other methods of eradication of a single symptomatic varicosis supplying a kind of ulcer in an elderly individual. And it has been admitted by the European Society of Vascular Surgery that phlebotomy can be used as a tool treatment of varicosis or in conjunction with some other methods like the intravenous laser ablation or the radiofrequency, or even in conjunction with stripping. The procedure is done in a progressive way, extracting the vein from one incision and proceeding to the other, and the perforators are grasped, eliminated by gentle traction and torsion, and without the need for ligation, because controlled bleeding is done only by compression, without the skin closure to allow the extrusion of the material, which allows a proper and better shorter healing. We can elevate the limb for 5-10 minutes. This may help control the healing and ease the edema afterwards. Post-operative bandage is mandatory, and bandage can be used by stocking in 1 or 2 layers, and if the patient uses the 2 layers, the topmost one should be removed by night. We can have the ambulation, which is one of the instructions the patient got to know, because no patient with venous surgery should be confined to bed to avoid anesthesia. Patients may return to work immediately, but they are instructed not to drive because of the motor dysfunction introduced by the intermittent anesthesia, especially if we are targeting an area like in the oblique region. Dressings can be removed after 48 hours, but the compression stocking can be changed after 4 days, take a shower, and then maintained for an average of 7 to 21 days afterwards. And we don't need to rush toward the complementary sclerotherapy immediately after phlebotomy, because many of these cholangioplasia and hemiplegia, the residual ones, can vanish after phlebotomy, and in many cases we may not need to do any kind of intervention anymore. This is a kind of the results got by the ambulatory cystectomy, and you can have a very nice appearance with vanishing of the whole distribution of the vein and all around the material. Different sites from different views can show that we have more or less a pleasant appearance without residual vein. But nothing for free, except in the heaven we have some limitations for phlebotomy, like having been used in the popliteal fold on the dorsum of the foot, or the prepatellar or pre-tibial areas, because starting this kind of veins may be difficult because of the adherence of veins in this area to the Kaifu fatty tissues around, and it is difficult to extract them. So we will rush to some kind of other service at this time. So when to use flebectomy and when you can go toward sclerotherapy, it's a kind of location of the vein. So as I said, if it is in certain sites like in the dorsum or the tibial or pre-tibial or the patellar area, it is better to use the sclerotherapy. Again, the size of the vein, if you have a thin vein, then you can use the sclerotherapy. On the other hand, if you have a thick vein, then you can use the flebectomy. This is the indication for the sclerotherapy and the flebectomy, and we can find that the flebectomy covers more of the indications in different kinds of varicoses, while sclerotherapy is maintained only for 3 indications, like in the pudendal veins and the residual after surgery, and for telangiectasia. So what is the advantage of flebectomy over sclerotherapy? Some risks of the sclerotherapy involve the intraarterial injection, the iatrogenic devices, DVT or BE, skin necrosis, or residual IR pigmentation. In addition, sclerotherapy is different from the anatomical flebectomy, because flebectomy totally prohibits venous recanalization with zero risk of recurrence, because it totally ablates the veins with no residue left for enrichment. Advantage over the traditional direct attack to the veins, because of flebectomy uses a little or no scar under local anesthesia, so all major complications combined with direct attacks are avoided with flebectomy. Some of the complications that may ensue during the flebectomy include some of the cutaneous, like hematoma, like bleeding, which is minimal, sometimes infection. It is very rare, but has been recorded. A nerve injury is one of the complications. So we go through these kinds of complications, like the nerve injury, severe infection, or skin necrosis, which happens because of the high pH introduced by the bicarbonate and the tumescent anesthesia. Some of the complications may be lymphatic to the system, especially if you are starting lesions like in the pre-tibial or medial areas, and all it needs is just function and drainage or massage. Superficial thrombophlebitis in the residual veins may develop, and after removal of the neighboring veins. DVT is very rare because of the ambulation and application of a bandage or elastic stocking. One of the complications is what we call it new telangiectasia, or the telangiectatic matting, which is a process of bluish hue that develops around the started veins, either by flebectomy or sclerotherapy, with an unknown cause. But sometimes it may be referred to the development of a higher venous pressure after ablation of some of the veins, or it is due to residual reflux. That means you need further correction of this kind of flux. Sometimes it may be due to angiogenic response to the trauma, which is a part of the healing process. And some of the authors referred to the exogenous estrogen, but it wasn't proved that telangiectatic matting, you got to choose the patient that it will disappear within a few weeks or months. And telangiectatic matting, don't rush towards sclerotherapy, because it will reappear again in a wider area distribution. And if it doesn't vanish in the proper time, you may need a pulsed dilator or a kind of light therapy. Injury to small veins is commonly found with general or spinal anesthesia or regional anesthesia, and it is less with the local anesthesia, because with the local anesthesia, a patient still can feel some pain, and the surgeon may stop the process to avoid nerve injury. If it happens, it may give a kind of hyperesthesia, hypoesthesia, or total anesthesia, which disappears within a few weeks or months, and it doesn't need any attention. Recovery of the patient usually happens within 3 to 4 weeks, and the patient should be asked to wear the kind of left stocking throughout the scattering period, because the sense direction of the blood flow in the healthy veins, and avoid edema, avoid pain, avoid any incidence of DVT, and patient may go to his work in a couple of days. And thank you very much.
Thank you, Professor Sullivan. Because there is now a good connection with Victor, I ask a comment from Victor about the comment from Vasila. Vasila, she presented a paper in which appears that there is no good results, better results in comparison to stripping about the cryosurgery. Please.
Pierluigi, Ayman put me in a bad situation, and I start my presentation saying that we can keep digging, we can keep looking for something else that already doesn't have good results and will be just putting us behind, and it's not much better than the regular stripping. And this is the final conclusion when you are talking about cryosurgery. The result is not good as we can. The comparison between the regular stripping and cryosurgery was really, the results are very poor. And even if we do like thinking about complication and better outcomes, they don't have better outcomes. And even worse, because you have to bring a large machine in your OR that is usually a big trouble for the people who do surgery. And right now, as everybody is aware, I saw the presentation of Dr. Sullivan in phlebectomy. He's doing just very good without big trouble and very good results. And this is the final idea. Do it as simple as you can, do it as easy as you can, and don't add new stuff that we are already know that will not improve in the result that we have already. Wasila was really right, and their conclusion was really excellent.
Thank you very much, Victor. I'm sorry for the connection, but the concept is very clear.
I have a question for
okay. There is another comment from the panelists.
Yes, I want to ask Victor. Yeah.
About the presentation of Sullivan.
No, excuse me, I want to ask Victor first.
Please.
Waiting for your question, Ayman.
Yes, thank you, Victor. It was very good presentation. I enjoyed the first part of your lecture, as usual. But I may ask you, in doing cryosurgery, we have to disconnect the saphenofemoral junction, then we insert the probe from above downward.
When we can do it in the reverse direction, we don't disconnect and go with probe from down till 2 or 3 or 5 centimeters from the saphenofemoral junction, and then start cryo probing. What do you think?
The final idea with the new method is that the probe is large enough to go through without big trouble, because it's soft and you can go and go past through all the valves that can put you in trouble and going behind backwards without big trouble. But as you are more than aware, that you have some trouble because sometimes there are still valves that they are working, and this will be just put the probe outside of the vein and do a leakage over there, and you will have a trouble when you press the full switch and put down the temperature. But this is a very really good question, and my situation would be just like this. I would just do the ligation and go from below to above without big trouble, trying to avoid mistakes with the probe and looking for with trust illumination that the probe is already in place, because sometimes it can go out. If the place is going out, you can be in trouble when you press the switch foot and you just go down with the temperature.
Thank you, Victor. Hyman, we have other comments, or we can close the session?
I have a question to Dr. Soliman.
Okay, but still we
Please,
have time
Solomon.
to ask you. Wait a minute, we'll ask the floor if they have a question for you, Victor. You have the questions for cryosurgery for Professor Kanata?
Okay,
Fine.
please.
Okay. Now you can ask your
Question, and I will replace Dr. Solomon because he is not joining us today because he asked to join the OR just few minutes ago. I may ask instead of him.
Okay, the question is like this. I was talking regarding about who will be answered. The question, how will be improved the way that we treat the saphenous vein and we do taking care of our patients. My question is, we will rely and again on the people who collect data and just taking care of paperwork, or we will just rely on we that they are the ones who are seeing the patient, looking at the patient, watching the patient, mapping the patient, and taking care of the patient, and we are seeing before and after of all those patients. And this is something that we have to fix. This is something that we have to just make a final rule regarding about who will be the one with the final word. And this is something we have to fix as soon as we can. And this was my question for Dr. Solomon was that how many surgeries he is doing with his procedure in a daily month in his office or maybe in his hospital.
I think
We pass the question to Dr. Solomon.
yeah, I think he has.
To answer this question himself. But I ask you, what do you think about the technique of multiple phlebectomy in the era of sclerotherapy and non-invasive techniques? Do you believe the multiple phlebectomy has a role nowadays?
This is the best thing that can happen in your life. If you know the technique, if you know that you have how you can do it, you can remove the vein of a patient without big trouble. But the problem is that we are not telling the patient to rely in the surgical method. We are telling the patient just to rely in laser, to rely in MOCA, to rely in some new technique that they are really just a new stuff that will sometimes fails. You will never fail if you do a removal of a vein with stop avulsion and you with phlebectomies. You will do a very good treatment without big trouble. If you know the rules, do a good anesthesia, the patient will not feel anything and the result will be really good and the patient will be very happy with the results. And this is something that we have to go backwards and we have to tell the patient that removal of short segment veins has very good results already.
The better method is the best for the patient, for the quality of patient, for the satisfaction of patient, without the complication, or reducing the complication.
I agree 100% with Pierluigi.
Okay, every method is good, but it's very important the expertise of the operator and the good results.
I think you have some comments.
It's here in Alexandria. Dr. Tamer, I think you have a comment for multiple phlebectomies for treatment of varicose veins?
Actually speaking, when we do the modern techniques like radiofrequency or laser, we combine them with some multiple phlebectomies actually to gain better results. And sometimes we have recurrence from missed veins like some tributaries or some accessory great saphenous vein. So if we can pass this to the floor, what we can do for these veins? Shall we go for another session of radiofrequency or we can go for phlebectomy again?
what would be easy for you? For me, just give 5 cc anesthesia over the just 3 to 5 centimeters to saphenofemoral junction, locate the vein, and removal without big trouble. I don't require to use the machine. I don't require to use just putting through the probe for the radio frequency, and it will be, will be just 5 minutes work, and the results were very good. In another way, I will have the same reimbursement if I do a staph phlebectomy instead of a radio frequency.
Okay. I think we have also a comment from
the radiological point of view. Dr. Khalid Al-Affas wants to comment. What are the radiological or duplex data that enables for a better doing phlebectomies?
Okay, my answer would be so easy, since we are doing all the duplex sono in the office, you are able to see where is the leakage point, where are the veins that are failing, and what are the good veins. And those are the ones that you have to remove. After you mapping them and you're taking care of where are the veins, you will be able just to remove the one that doesn't work and leave the one that they are working without big trouble. And this is the final idea. There is something that we have to add, is like the duplex sono has to be done by the phlebologist before and after the treatment. And he is the one who has to be in charge of the patient, in charge of the surgery, and in charge of the duplex sono.
Okay, let us hear from him.
Thank you, sir. I'm honored to attend this distinguished meeting. I'm Khalid Al-Affas. I'm a professor of radiology in Cairo University. I'm asking about what would we gain if you combine intraoperative ultrasound doing phlebectomy instead of transillumination. So checking the veins which is incompetent, doing the phlebectomy or any other ablation techniques, then checking inside the operation by using ultrasound to check that we have removed all the refluxing or the pathological veins. Is it okay to do this, or you have another opinion to do this?
Professor Antonioni, what do you think about that? Doing intraoperative
This is
ultrasound?
not simple to hear, but if the comment is about ultrasound, I believe that the mapping of the vein is preliminary and mandatory for all patients. Only on basis of mapping we can decide the best method to use.
My question
We
is inside the
need to have a picture of a patient by ultrasound before any treatment. I think Victor is agree completely.
Excuse me, Dr. Khalid was asking, can we do the marking of the vein intraoperative, not preoperative?
Checking that we have
checking
updated
immediate
and removed all the
results.
veins.
In one session, intraoperative, mark the vein, remove it, and check the results immediately. In one session, 3 steps in one.
This is the way that we're working right now in my office. I have the sonogram machine inside. I just finishing the case. If you are listening, I just done with the case that I've been doing it. I do a laser plus some kind of stuff doing ablation of some veins that are down below the knee, and the sonogram is over there. And after I finish, I will just check what's going on, how is this happening from the junction, if the patient doesn't have any trouble, and then put the bandage and send the patient home.
Okay.
Yes, we control immediately the patient after the treatment. Then after 1 week, after 1 month or 3 months, according to the kind of treatment.
We have the last comment from Dr. Nasser Said.
Thank you for your nice presentation. I'm actually wonder about the gator area with lipodermatosclerosis. What is the ideal or the best option to deal with? Multiple phlebectomy or just foam injection, or what you are going to do from your point of view? Did you hear my...
Dr. Nasser is asking about...
Because this is a challenging area for us long time ago.
Dr.
So leave it
Nasser?
alone or inject or whatever.
Dr. Nasser is asking about doing phlebectomy in unhealthy segment. At the gator area with unhealthy segment with the lipodermatosclerosis.
I just would like to make my type.
Please? Okay, he will ask. Okay.
I'm Dr. Nas Sair. I am sorry.
It's the final question. Because
Yes. My question, to make things clear, I am wondering about the gator area with lipodermatosclerosis. The skin will be very tough, tissue fibrosis with some ischemia. So what is the best solution to deal with the multiple varicose vein in this area? You're still doing phlebectomy in spite of we are worried about the healing, or it's better to do foam injection and we are worried about the result because the compression here is not enough usually. So what is the best? Thank you. Did you hear me?
Yes, I hear you. There are so many stuff that you can use. I'm not afraid of using phlebectomy or foam in some patients that maybe they are in the gator area, because I'm more than aware that I will use the less powerful foam that the patient requires for the diameter of the vein. Because I have to go, I want to make sure that the patient has 100% safe and didn't have trouble. Because if I use foam, I can repeat it again as much as I want. The other thing that if I want to make rid of the vein and take the vein away, I will use phlebectomy, because I will be more than 100%. I will remove the vein without big trouble. It's just only a small anesthesia, and the vein will go away without big trouble. But both methods are safe and secure as far as they use it wisely and without big trouble.
So I just would like to add something. Is there still any role for subfacial ligation endoscopically in this area?
This is some tricky stuff that you are putting out, because if you saw some perforated veins in that area, I will just doing foam before 1 week before the final treatment. I will just foam the area who has the sclerosis, the perforating vein. Then I will wait just a little bit just to see if the foam injection of the sclerosis of the perforating vein is already occluded, and then I will finish the treatment with the problem of the patient after I know that more than aware that I fix the perforated vein first.
Okay, thank you for your
I agree completely. Well, Ayman, you...
Yes,
wish
please.
to conclude?
No, we still have a talk from Mark Whitley. Okay. Please.
Actually, I'm afraid that at the end of this discussion, we are complexity. Do we go for Chiva surgery, or laser, or microwave, that is, or radio frequency, or we don't approach the long stiffness at all, just ligate the perforators and tell the patient to go away. What is best? I think we have this problem in all of our minds, what to do with our patients, what is the best for them. We are trying to reach to a conclusion. What is the best for our patients? There are many, many approaches. Most of them destroy the longosaphenous vein. Only Shiva does not destroy the longosaphenous vein. What are we going to do now? What are our conclusions at the end of this discussion? That is my question. Thank you.
I think now we have to listen for Professor Mark Whitley. He is going to talk about stop surgery and go Kaifu for the treatment of varicose vein.
Okay.
Mr. Chairman, ladies and gentlemen, I'd really like to thank the organising committee and particularly Professor Fakari for inviting me to give this keynote lecture entitled Stop Surgery and Go Kaifu for the Treatment of Varicose Veins. I think this is a little tongue-in-cheek and probably premature, but certainly, although I wouldn't really say go Kaifu today for all varicose veins, I do think it is going to be the thing in the future. In 1998, we introduced endovenous thermal ablation with tumescence into the venous world, and of course this was a complete change from the stripping. In 2011, many workers started introducing non-thermal, non-tumescence ablation, thinking this would take over from the endovenous thermal ablation. Many people were using mechanical-chemical ablation and also glue. In the past, people thought that foam sclerotherapy might actually be one of the non-thermal, non-tumescent techniques that will be useful in truncal veins, but in fact the randomized controlled studies have shown what we all suspected, and that is that the results are not very good for truncal veins. In 2019, however, we then moved away from this idea of non-thermal techniques to a non-invasive, high-intensity but thermal technique called sonovane. And this produces thermal ablation using high-intensity focused ultrasound, and, if needed, targeted local anesthesia. So what have we learned about venous ablation? We know that if we look at the old stripping techniques, there's a very poor long-term result due to varicose veins starting to grow back again. And we showed this in 2007 in the British Journal of Surgery, where we showed that veins that have been stripped out just grow back again without any valves. The principles of endovenous thermal ablation, though, are to actually put something inside the vein and then to inject tumescent anesthesia outside of the vein to act as a heat sink, a vasoconstrictor to hold the vein against the device to make sure there's good heat transference, and finally to act as a local anesthetic. And then whatever heat source you wish to use, you can then ablate the vein with. We've previously published from our unit that if you do this, you don't get any neovascularization, and so we don't have the problems of veins trying to grow back again. And we also found that tributaries are not a problem, provided you treat the anterior accessory venous vein. So the idea that you have to close right up to the junction due to tributary reflux is incorrect. And we've published our results up to 15 years after treatment. Although I only introduced endovenous thermal ablation to England in 1999, within 10 years you can see that it was already becoming the accepted treatment for the incompetent truncal veins in the international guidelines in America, in Europe, and in the UK. Now, getting a bit more into the science of this, many people still say that endovenous thermal ablation and sclerotherapy affect the inner vein wall, effectively sticking the vein together. However, in 2004, we published our theory that, in fact, you have to ablate the whole of the vein wall, and now virtually everybody accepts this is the case, and we've published a good deal of evidence, both clinical evidence as well as immunocytochemistry, showing that this is in fact the mechanism of ablating veins. I've published this several times, not least of which in my book on leg ulcer treatments, showing that, as we can see on the left here, if you have a vein, if we follow the top line, you can see that if you only have the intimal or endothelial damage, the vein looks closed because you get intraluminal thrombus which will only recanalize because the vein is still alive around the outside and the thrombus just recanalizes. If, however, following the bottom line you have transmural death, you end up with fibrosis of the vein wall and complete involution. And this is your permanent closure, or fibrosis as some people like to call it. So what is high-intensity focused ultrasound Kaifu ecotherapy? Well, the Sonovane machine made by Theraclean is this very large machine that focuses ultrasound through the skin, targeting one section of the vein, as we can see here in this diagram. The machine has two ultrasound parts. The first ultrasound part is this grayscale ultrasound, which is used to aim the ultrasound beam. The second ultrasound component is the dome-shaped area of the Kaifu machine, which causes this focused cone of ultrasound to be focused at one point just below and always at the same place, with the in line with the two-dimensional grayscale ultrasound. These current slides now will show you how this works. Firstly, the two-dimensional ultrasound here gives a grayscale image, and on this side we can see the great venous vein with some targeted local anesthesia around it. When we're satisfied with the position, we can then fire the high-intensity focused ultrasound that focuses at this one point. And on the right-hand side, we can see this classic shadow of this white X, which is the bubbles being formed in the vein wall and reflecting ultrasound back, and these dark areas either side where there's no reflection from the local anesthetic. Immediately afterwards, we can see the great venous vein as this white blob, which is full of gas, or which in this case, of course, is going to be mainly water vapor, and this shows the heat that's been formed within the tissue, ablating it.
Say stop straight away if you feel anything. How's that feel?
This slide just describes what sort of ablation effect we get, and what we can see here, the focused ultrasound gives this little area or a little volume of tissue that is ablated, and as we can see here on the diagram, this is ablated about 90 degrees centigrade, which is enough to kill cells and cause thermal ablation of tissue and contraction of protein. And over the 8 seconds, about 5 millimeters in height and 3.5 to 3.6 millimeters in diameter of tissue is fully ablated. On the original Sonovane machine, there is also the option to switch to a 4-second pulse, and this 4-second pulse also produces 90 degrees centigrade and approximately 5 millimeters high volume area, but this volume is 1.2 millimeters wide, so it's a much narrower area, which is represented because, of course, it's a shorter time period. Now, as far as our understanding of the transmural death, because the Sonovane comes in as high-intensity focused ultrasound from the outside and, of course, passes through, with the focal point being at the vein, either totally encompassing it in a small vein or in a larger vein, partially encompassing it, we still get the heating effect transmurally right across the vein wall, which should lead us to fibrosis and involution, just the same with successful endovenous thermal ablation. So although we thought Sonovane was fantastic with this non-invasive Kaifu, in 2020, Theraclean brought out Sonovane S, which is an upgraded machine, which is much faster, and it gives the possibility of Kaifu or ecotherapy, but in many patients with no local anesthetic at all, because of the speed of treatment. Sonovane S is an awful lot faster. Instead of 8 seconds or 4 seconds with a cooling time of 40 seconds, each pulse of Sonovane S is 0.5 seconds long with a cooling time of only 8 seconds. The actual target area and the volume that's ablated still is 90 degrees centigrade, although it must be said it is a smaller volume. However, with the increased speed, many patients find it much more acceptable. Therefore, because of this increased speed, not only of the pulse, but also because the cooling is much quicker at only about 6 to 8 seconds, we are able to treat longer sections of veins. And in about 50% of our patients, they don't want any local anesthetic at all, which makes it much easier to find the vein with the ultrasound, because there's no anatomic disturbance of injecting local anesthetic. So we performed our first commercial cases in October 2020. This is an example of Sonovein S that I performed last December of the right great venous vein, and you can see the position that I placed the patient in. So with Sonovein and Sonovein S, we have to make sure that the leg is held in one position, and so we use this inflatable cushion which holds the leg still. We then position the treatment head over the vein exactly where it needs to be positioned.
And we can see here the great venous vein there, straight away. Going into the junction there. There's advantage on this. Here's advantage on the surface. You can go exactly down here. So we can see the vein here in the middle. So now we have the great venous vein here, we go to positioning. So the laser onto the machine there, laser set, bring the skin down, and then we're more or less going to start here. What we're going to do first, I'm just going to come up to here. Here's the junction I want at that point there. Green vein right in there. So there's the great venous vein. We can go to the longitudinal view. And there we are. And in the longitudinal view, we can see the vein here. It's coming out. Just a little bit of moving. I'd like to see the longitudinal section of the great venous vein. So here we can see the great venous vein here. Doing that. Okay, so we've got the great venous vein here. We're right on it. We know where our longitudinal. We're going to look here. The skin is in the right place there. We can just go up a little bit to check the great venous vein higher up. See how it's starting to drop down there through the sphenoid junction, and we can come all the way down the great venous vein here. Comes up there. It's almost that point, so almost definitely going to need a little bit of local anesthetic for this one, but you can see it's all in one place. So as long as the patient stays still, it will be the right place. Let's give this a look. That's in the junction there.
So in patients where this is needed, we can then inject targeted local anesthetic under the balloon. The pressure of the balloon as well as the coldness makes it so that most patients can't even feel the injection, but on the ultrasound we can see where the targeted anesthesia goes around the vein, making the vein even more obvious.
So we can see there's the vein just there. You can see. I'm just going to put a little bit of pressure on. I'm just going to try and see if we can squash the vein a little bit. Just to try and keep the
She's the star. Yeah. You know, it's like outside. Two and a half.
Beautiful. So if you just from there, you'll see how it's the vein before and after, before and after. So once you've actually completed those centimeters, we now mark where the jump is on the leg. We then go back to here, do an end treatment, new segment for the current position, yes. And then holding this exactly so watching the vein we've got marked already. Press the little button on the head. The computer the robot arm resets itself. And you're all set to go straight to the same place again. But now you've got a whole thing. You lock the laser in place, make sure the skin is in the right place there. And there we are, we're on the vein now. We're ready to go again.
So by the time we get to the bottom of the vein, you can see here, we've treated down to just above, or about the mid-thigh, and the whole of the vein on the right-hand side you can see has been treated in sections marked by these black dots. Turning to how we treat perforated veins, we can see the perforated veins very clearly, and we put the treatment head directly over the perforated vein, and I usually put them into a longitudinal axis. You can see here quite clearly the perforator coming through from the muscle underneath through the fascia. We can see where I'm targeting the perforating vein as it comes into the subcutaneous tissue. When we fire, we can see the reflection on the seno venous as well, showing that we're getting successful ablation because the gas is being formed in the target vein. Immediately afterwards, we can see the gas reflected here, and you can see the perforator has been ablated. We usually have to perform probably about 10 to 15 shots to make sure that the whole area is completely ablated permanently.
Yeah, it's a tiny bit.
Just a tiny bit. Not too bad?
Yeah.
Not bad enough to be sat Carol?
No, not at all. Not yet.
I can't suck any of it back out. No, this is, so basically the position puts you now, how long have we been operating? 10 minutes, 15 minutes?
Started at 5 to 2, it's 5 past 10 minutes.
10 minutes, right. So we're normally where we'd be now with the old technique, we'd probably have been about 40 minutes. So that's why I'm so in love with this technique.
Initially, to try and save patients time, we were performing sonovein to truncal veins and perforators and immediate foam sclerotherapy for varicosities if needed. However, we've now found that many of these varicosities will recede in time, and so what we do now is we do sonovein to truncal veins and perforators and then leave at least 8 weeks for the patients. In this way, we only have to then perform foam sclerotherapy if strictly needed. Last weekend, I presented our 1-year results of the initial sonovein at the AVLS, and we'll be shortly publishing these. And we broke down the results into those patients who had had sonovein only, those who had had sonovein with immediate foam, and those who had sonovein with delayed foam. And needless to say that we are getting to the sort of treatment success rates that we would have expected with endovenous surgery in about 2001, having started in 1999. So we've still got a little bit of a way to go, but certainly the results are very promising at present. So, conclusion, Mr. Chairman, ladies and gentlemen, Kaifu with the sonovein is totally non-invasive. The only thing that's invasive at all, if you need it, is the targeted local anesthesia, and many patients now do not need this with sonovein S. The early results do suggest that the ablation, if done properly, is as effective as the early endovenous thermal ablations. It can be combined with foam sclerotherapy for surface veins, although we now think that it's probably better to do the foam sclerotherapy later. The new sonovein for S is 6 times faster, and as I said, at least half the patients don't need any local anesthetic at all. And very importantly, it's really essential that whenever we use new techniques, we make sure that we do follow up patients and see whether the results are good. And the only way this can be done is in a venous registry. So the College of Fluorology Venous Registry, which some of you might know already, where we already watch the results from radiofrequency, foam sclerotherapy, steam, microwave, as well as laser, we've now added the Kaifu to the venous registry, so that anybody using Kaifu or any of the venous techniques can now monitor their own results and benchmark them against other doctors internationally. Thank you very much for your kind attention, and I hope this has given some insight into what Kaifu is likely to be able to do in the world of venous surgery.
Thank you, Mark. I think now we have some
concept. I myself in favor of stop surgery and go Kaifu. Although it is expensive machine and it needs a high learning curve, I think it's worth to learn it and prepare ourselves to be ready to establish this technique in our practice. I leave the mic to Professor Antoniani, and I welcome Professor Lowell Kapling to join us. Also, we have Dr. Rag and Dr. Samir Kusayer. We enjoyed your company all. I leave the mic to Lowell, Dr. Lowell Kapling, and say a few words. Then I leave it to Professor Antoniani to wrap up or conclude the session. Please unmute yourself, Professor Lowell.
I was having a little bit of difficulty with the audio, but anyway, I'd like to thank Eamon for the opportunity to talk. It was very interesting, Professor Whiteley's experience with Kaifu. I've watched his experience over the past 2 years. It seems to be getting a little bit more advanced. There are obvious issues with Kaifu at this point. I think you mentioned the learning curve and the time of which it takes. But let's be optimistic. I mean, we started with radio frequency, and when we started with radio frequency, it took us 40 minutes to do, and then they upgraded it. So constantly, the advantages of the next generation, you can actually see where it's going to go. At some time, I believe that this will be automated with artificial intelligence. You'll have a technician there who, just like our technicians who do MRs and CAT scans, will be able to do this in the office. And so I'm excited about the future of this type of technology. Whether it remains to be this technology, I don't know, but it really has some opportunity. I would love Dr. Whiteley to comment on the downsides other than time, any of the complications that he's seen and things to avoid. I do know that there are at least 3 machines out there in the world that people are looking at and using. So thank you very much for the opportunity to talk. I appreciate the opportunity. Dr. Antoniani?
Yes. Any to conclude the session?
I'm not seeing him, Ayman. I think you have to close.
Okay. Thank you, dear professors. Thank you, Professor Caneta. Thank you, Professor Whitley. Thank you, dear professors.
Thank you, Professor Antoniani, Lowell Kabnik. I enjoyed your company all. It is a great honor for me. Thank you, Wasila. Your comment was great. Now, let's have a coffee break for 15 minutes and rejoin again at 5 p.m. See you there.